Refractive surgery outcomes rely more on case selection than technique. Today, I'll focus on a practical algorithmic approach to evaluate a patient for refractive surgery. So, we all know it provides spectacle independence, it corrects the aberrations, and the threatening complications are rare. So, these are the FDA approved age limit given for each procedure. The most commonly done procedures are surface ablation, LASIK, SMILE, phakic IOLs, and refractive lens exchange. So what we pick up in history often eliminates the unsafe candidates before touching the topographer. So counseling is of utmost importance prior to taking up a procedure. So we have to see what the patient expects, whether the patient will be coming for regular follow-up, whether the patient has any um, risk factors, and always an informed written consent should be taken. So the preoperative evaluation should include what the patient expects from the procedure, the profession of the patient, any ocular history, any contact lens usage, the refractive stability, any systemic history, any other risk factors, drug history, and any other comorbidities. So contact lens usage is important because it ensures appropriate washout to avoid misleading topography, and contact lens should be discontinued before the patient comes for workup. Now, symptoms like dryness, allergic, and eye rubbing can indicate keratoconus tendency. So, what should the patient expect? So, the patient should expect that whatever he can read with his corrective glasses, that will only be achieved with refractive surgery, and it cannot treat amblyopia. So, the occupational needs should be evaluated, especially patients who are involved in defense and pilots, then night drivers. They require stricter screening, and some people need their near vision to carry out their day-to-day activities. Now, systemic history is also important. So, these are not very good candidates for the procedure. People who have uncontrolled diabetes mellitus, people who have propensity to develop scars and keloids, immune deficiency, collagen vascular disorders, medications like sumatriptans, isotretinoin, because most of the patients who come for the procedure are younger patients and they are prone to acne, migraine, and they might be taking these medications also. So triptans can increase the risk of epithelial defects, and tretinoin can gives rise to dry eye and affect wound healing. Pregnancy and breastfeeding is also are contraindications for refractive surgery. Now, when the patient walks into the room itself, the patient should be evaluated whether the patient has any broad nasal bridge, any deformities in the face. These can affect docking procedures. Whether the patient has any active vesicles on the forehead, which can indicate herpes. Now, whether the patient has any squint. So the examination will include visual acuity, refraction, ocular dominance, pupil size, and IOP measurements. Refraction should be accurate and reproducible. We have to look consistency between the subjective, objective, and old glasses. Cycloplegic refraction is important in hyperopes and young patients. Always check that refractive astigmatism aligns with corneal astigmatism. So these are some of the ocular surface disorders which can be a contraindication to the procedure, like scarred corneas, large pterygiums, corneal ulcers, endothelial decompensation, neovascularization, and dystrophies. Posterior segments should also be assessed. Retinal evaluation and optic nerve should be assessed. Any lattices should be lasered prior to the procedure, and any patient with who are a DIS suspect should be evaluated for glaucomatous changes. Next is the ocular surface, which is often overlooked but is one of the biggest cause of inaccurate refraction and poor postoperative quality of vision. Tear film should be assessed with Schirmer, T-BUT, meibography, and OSDI score if needed. A compromised ocular surface must be treated before any measurements because this can dramatically improve topography regularity and reduce false cylinders and improve postoperative comfort. So this is a non-invasive tear breakup time from a topo machine. So this shows the first breakup time and average breakup time. So this shows that the post-operative recovery of the nerve fibers. So note that the viable fibers are visible at 1 week and 1 month after surgery in SMILE group, and partial recovery of the fiber density starts at 3 months after LASIK. So other investigations include topography, pachymetry, pupillary assessment, wavefront analysis, corneal biomechanics like Corvus if available, ocular biometry, and specular count. So topography is the heart of refractive surgery because it detects risks. More than detecting keratoconus, it excludes patients who are not a good candidate for the refractive surgery. So there are various ectasias or various borderline groups which are not a proper candidate for cornea-based procedures. So like this patient was a borderline patient, the other one was a keratoconus patient, and this shows the CTSP curve of the same patient. So pachymetry is also important because we have to calculate the residual stromal bed and the percentage of tissue altered. PTA above 40 has been associated with higher risk of ectasia. Now, aberrometers are used to determine the ocular aberrations and to provide customized treatment plan. It adds quality dimension to the treatment. So, high commas such as the need for a topography guided approach. So, this is a Cernicke order showing various type of aberrations. Now, coming to white and anterior chamber depth, these are important because this is used to calculate the ICL power sizing. Also, white is also used to treat the to get an idea about the treatment zone of the laser. So borderline white can exclude a patient from phakic IOL surgeries, and optic zone selection for laser ablations in smaller corneas, and predictability of centration in topography guided treatment. Anterior chamber depth is also important because adequate wall should be there for an ICL to be placed to avoid postoperative complications. Now, the corneal endothelium maintains corneal clarity by regulating a stromal hydration. So, procedures like ICL, RLE, and high myopic laser ablations can lead to endothelial decompensation. So, eligibility for ICL we already know. A very low specular count is an absolute contraindication. Also, if the patient has a low ICD and borderline thickness, it is better to avoid procedures which put more pressure on the cornea, and surface ablation might be a safer option. So this is the manufacturer's calculation and ordering system nomogram for ICL size selection by Star Surgicals. Pupillometry is essential because mesopic pupil size predicts glare and halos after surgery. If the pupil dilates beyond the optical zone, night vision quality drops. It also guides optical zone selection and also helps in centration. So who's a suitable candidate? A patient who is of appropriate age with refractive stability attained, with expectations explained and no contraindications. So for a patient who has adequate corneal thickness, who doesn't have a steep cornea, we can go for a surface ablation or any other cornea-based procedures. If the patient doesn't have a proper cornea but is ACD and white to white is okay, then we can go for a phakic IOL or refractive lens exchange. And for very high refractive errors, we can go for a bioptics. So these are the take-home messages. Proper counseling, detailed history, systemic status of the patient should be assessed, treat dry eyes and allergies, thorough examination of the posterior segment, avoid procedures in patients who are prone to develop RD and glaucoma, select the appropriate procedure, adhere to the protocols, and be available to the patient's concerns. So better screening prevents complications more than technology ever can. Thank you.
So an official good morning to my co-instructors and Dr. Priyanka. No, Vinay too. Yeah, specifically പറഞ്ഞു load ചെയ്തത്. I think I'll go back and ask the person why it's not sure. എനിക്ക് കോപ്പി ചെയ്തു തന്നിട്ടെന്നെ. versus surface procedures in refractive surgery. So uh, the basic thing is to weigh the subtleties of doing LASIK, which is a flap-based procedure, or any flap-based procedure, versus a surface ablation, where you preserve more of the cornea and do it exactly on the epithelium. So now, what we mean by a flap-based procedure is that we take either a keratome or femtosecond-based flap. So here you can see the mechanical keratome that has raised the flap first, followed by the femtosecond laser. So depending on what is being used, the smoothness of the elevation could be different, and the way the meniscus is formed could be different. Then this followed by application of the laser, excimer laser, to the stromal bed, followed by repositioning of the flap. So now you have a covered area over which, over the excimer ablation. Now, on the other hand, trans-PRK, which is what is followed now more than PRK, is where the ablation is done on the surface. It's the laser itself that removes the epithelium and then carries out the excimer ablation. So, because of the flap, the patient discomfort is much lesser. It lasts for a couple of hours till the epithelium on the margin of the flap heals and blends with the rest of the cornea. A wide range of power can be correctable in the normal cornea. Pre-op workup is crucial for both procedures, especially in LASIK, where you're going slightly deeper than trans-PRK. Now, these are some of the complications that can happen in LASIK. So, you see that here a keratome has been placed. So, and as it runs, so whenever there's a flap, there are likely to be complications associated with the flap. So that is the basis for most complications in LASIK, especially with novice surgeons. And you see, as the keratome run gets over, there is a split in the flap. So this is a dehiscence right there in the flap. You have a smaller portion there and a larger portion on the other side. And then this cut that passes through approximately 1/3 of the flap. So once it heals, you'll see there that there is a small scar. If it's in the visual axis, it would be extremely disturbing to the patient. Now, in small eyes, especially when you have very contracted sockets and the patients are not able to open their eyes much, the keratome may stop midway. It doesn't complete its full run, and you can have a hinge prematurely, like you see over there, a large, long hinge. Plus, if there is undulatory movements of the blade, you can get something like buttonholing that may not be through and through, but can cause elevation in the stroma. So these are sources of aberrations, basically. So what we do for that is open the eye very well whenever there's an applanation or a motor needs to run in the eye, or pressure needs to be applied, so that the movement of the keratome is free. The ring should also be placed very well inside the speculum. Now, this is what happens when you have done the procedure, repositioned the flap, and then as you're taking out the speculum, there could be slight movement of the flap. So you need to float the flap again and then put it back and then dry the surface as usual. Now, what happens if the same thing happens after a day is that more epithelium grows on the surface and it tries to, smoothen out the surface. So you can see these folds that are getting adherent to each other, and you need to, rupture the epithelium to just straighten them out. You'll also note that as you go to the periphery, and you lift the flap, the area between the edge of the flap and the rest of the stroma, cornea, is also covered by epithelium. So it's epithelium that's trying to, mend things over there, making it much smoother. And that's why it's harder to float the flap. And another thing is that you'll get a lot of striae on the flap. And those are daunting, for which you actually need to peel the epithelium off from the top of the flap before you reposit completely. So this is what's being done over there. You can see that the epithelium is being removed so that you can smoothen out the flap much better. There may be a few folds left when you're completing the procedure, but on the next day, it comes out to be very smooth. Epithelial ingrowth is another factor that can happen with LASIK because of the presence of the flap. Then another thing is the ablation. the slight incompleteness of the ablation if the hinge corresponds to the axis of the cylinder, which can happen with keratomes that take flaps only in a particular direction. There are keratomes that take only in the superior direction. There are those that take only in the nasal directions, but those that can be rotated, like you see over here, the Moria M2. Here, when the ablation falls on the hinge, then there is ablation of both the hinge and the stroma adjacent to it, because of which when the flap is reposited, there would be a small depression in that region. In the periphery, it doesn't make much of a difference. But if the hinge is premature as well, then that's when it compounds the problem. So for an ablation at around 40 degrees, it would be wiser to take the hinge at 110. And likewise, depending on the orientation of the cylinder, you can move the hinge around. Now here is an opaque bubble layer that can happen with a femtosecond LASIK. This can usually happen if the energy is on the higher side, or if you are using a thinner flap, especially with 90 micron flaps. I had done a study where with 90 micron flaps, we found that the OBL is much higher. So it goes off in a bit, but sometimes it could produce small pillars of tissue between the stroma and the flap, because of which elevation of the flap becomes a bit of problem. Sometimes eye tracking may be a problem. The amount of laser, the fluence of the laser when it reaches the bed may not be actually what shows up on the screen. So all these are small problems that may be associated with it. Another factor is air in the anterior chamber that can happen. Again, in femtosecond laser, it's not very common, but sometimes air can pass through the trabecular meshwork and enter the pupillary area. So that doesn't do much of a problem, other than it may affect eye tracking a bit. So you need to let the patient sit for maybe an hour or so till it clears up, and then take them out back again. Now, if you're able to track through and through, it's good. You can switch off the tracker off as well, but not recommended. Now, coming to the second procedure, now there's not much to show over there because you're just ablating straight on and then coming out. So the chances of complications because you're not touching the eye is much, much less. So now what is there in the back of any surgeon's mind is patient discomfort and chances of fibrosis, which is virtually nil when you're using mitomycin for the recommended amount of time. And with all the advanced lasers now these are the lasers, there's the Alcon map with its trans-PRK. So earlier the lasers used to create a more hyperopic correction at the periphery compared to the center. So now that's not so, because the blending is much more smoother, the spots are placed close together, and they're not large diameter spots. The epithelial healing is also relatively fast, because of which the patient discomfort is less. And one reason for that is that the edge of the epithelium is defined by the laser and therefore very, very smooth. So this is an advantage in thin cornea, dry eyes for higher corrections. And the last two are the most important in professions where you cannot afford to have a flap or a flap displacement, and for retreatments. So whenever you're treating, whether it's smile or whether it's post-LASIK, or doing on the surface is a much better option. So compared to olden days, the healing is much quicker, and like I mentioned before, it's a much more compact procedure than a long PTK-PRK combo. Ectasia is of importance in both procedures, but then, like Santon earlier mentioned, it depends on the pre-op workup more. Thank you very much. I call upon Dr. Aditya. So he'll be telling us a few things about the KLX procedure, because of which I had deliberately avoided it. He's an expert in that field. He's from Umai Clinic, Chennai.
So, morning everybody. Thank you, Swapna ma'am, for inviting me to your course. It's a real pleasure to be here. So, I'm going to speak about KLX very quickly in 8 minutes. So, let's discuss why transition to lenticular extraction first and how to transition effectively. So, as we know, LASIK is a proven modality of laser correction. But why should you even consider transferring to SMILE or any other form of lenticular extraction? So as we know, the main advantages in doing a lenticular extraction are as follows. One is there's no flap. We do all of the procedures through a 2 millimeter incision that preserves the subbasal nerve plexus, so there's less dry eye, better biomechanical stability, and the results are very accurate. But there's one thing that people miss when comparing SMILE versus LASIK. That's to do with the excimer ablation, which has an inducing cosine effect. So let's discuss this effect first. So when you do an excimer laser treatment, whether it be LASIK or PRKM, what we have to understand is the excimer laser is delivered ultimately via mirrors. So when you do this treatment on a prolate cornea, which is a cornea which is not touched yet, the central zone is treated more than the peripheral zone. So this leads to a cosine effect where the peripheral zone is not as well as ablated as the central zone. So we look at this diagram here. This is a diagram of an excimer laser performing a treatment on a normal prolate shaped cornea. So when the beams first hits the center, it's a very well spaced spot. There's no cosine effect. But as the treatment goes further towards the periphery, the peripheral spots are larger than the central spots. So this leads to a sort of like an uneven treatment zone. So the effective central treated zone is much tighter than the transition zone. So this is what gives rise to spherical aberration because the center is treated more than the periphery, and this effect compounds when you have higher degrees of myopia when you're treating. So this is why some people, when you do a LASIK and they have a high power correction, they complain of starburst, glare and halos. It's precisely because of this effect. When you do lenticle extraction, this effect is totally not there because it's a flat applanation. We use a contact glass to applanate the cornea, and this gives rise to a very even treatment zone right from the center to the periphery. So in lenticle extraction, whether you're treating a -1 or you're treating a -10, the time taken is the same. It's about 8 seconds. Whereas when you do a LASIK for a -1, it's maybe about 5 seconds or so. With -10, it takes almost 30 seconds. So that's the real advantage that not many people discuss about. The other things we already know, it's a 2.5 millimeter incision compared to a 24 millimeter cut in LASIK. And that's why this preserves the corneal integrity, better biomechanical stability, and much lesser dry eye. So I just very recently completed a study in my center of 1,600 eyes of Smile Pro on the Visumax 800, and the results are outstanding. So this is right from minus -0.5 to -10 with up to -4 cylinder. 99% of eyes achieve 6.6. Stability is very good, no loss of lines. 99% of eyes are within half a diopter of the refractive accuracy. Cylinder correction is also excellent, where the mean rotation of cylinder is within 5 degrees in at least 86% of eyes. So let's now move to the standard operating procedure. Now, if you're convinced about SMILE, how do you actually go about and perform the procedure in a standardized way? The most important step I would say is in the ocular surface preparation, where you have to prepare the surface and make it perfectly wet. It should not be too wet, it should not be too dry. So this is how we do it here. Ensure that the lashes are kept out of the way. You can use a tape to keep it out of the way, or you can use a flange speculum if you want to skip the tape also. Just very gently, just very gently irrigate the surface. So the cornea has to have an even film of saline, whereas the conjunctiva has to be perfectly dry. So this is what I do. Just one swipe on the cornea just to make it evenly wet. But if you make it too dry, it will have a lot of black spots. Docking is of paramount importance. In the newer machines, you can dock exactly on the corneal vertex. So the older machine on the Visumax and the other lenticle platforms, you dock only on the pupil center. Whereas in the Visumax 800, you have an accurate alignment protocol which allows you to dock exactly on the corneal vertex, and it tells you how far you are from the corneal vertex and helps you identify where exactly the treatment center should be. And that's it, you have perfect centration. Cycler torsion compensation is now also automated in the Visumax. Here I'm using the Visumax platform and doing the cycler torsion compensation. After docking, you can align the reticule with the marks that you have made in the slit lamp in the 0180. So any amount of cycler torsion can be very easily compensated. As of 6 months ago, even this has been updated where you just have to dock and it auto aligns according to the iris marks. If you have the IOL master, this can be done. So this part is also very well taken care of. Energy settings, you have to standardize. So the appropriate energy settings depends upon machine to machine. So some machines it has to be higher, some machines it has to be lower. Ideally, I would say start with the energy settings that the company gives you and then gradually bring it down, because the lower the energy settings, the faster the recovery. But as a beginner, keep it a little higher, keep the spots a little closer so dissection is easy. But as you keep getting more experienced, you can increase the spot spacing, lower the energy, so you will have faster recovery on day one. So this is what we have to see in an ideal energy pattern. So my machine is optimized over the course of the last 3 years, and we figured out what exactly the ideal energy pattern is. So once you dock and apply and give applanation, you can see the bubble patterns which are about to appear here. They'll be very even. There's no black spots, no OBL, nothing. It's a perfect energy pattern. This is ideally what you should get in every single case. I'm going to overshoot by another 2-3 minutes because of my instruction video. Okay, so how do you do the dissection? So we have to have an ideal dissection protocol to ensure that we're able to get the lenticule out in every single case. So here, what we do here is I open up the incision and I use this tip to lift up on the incision edge. So you don't go by mistake into the posterior edge. Ideally, we must open up the anterior edge very firmly first, and only then we should attempt to go under the lenticule and find the posterior plane. So when you do this, you will find that the bubbles will decompress. So there's an animation here. You take the tip, lift up on the incision edge, and find the superior pocket. And once you do that, you make a very small entry into the inferior pocket, so you identify where the correct planes are. So this is superior pocket. I'm lifting up here. I'm just finding the superior plane. So I move it end to end. So that's the superior edge. And now you can touch the edge of the lenticule. Just scratch it a little bit, you will find the resistance and make a very small entry into the inferior plane. Don't make the inferior plane entry too large in the first attempt, because if you do that, you might enter by mistake into the posterior plane and do a posterior dissection, which is going to be very difficult to retrieve the lenticule then. So again, you can just check twice, see if the planes are correct. So that's the superior plane, and under it is the inferior plane. Superior dissection, what you have to do is you have to go from end to end. So in the superior dissection, you have to dissect to the superior bias. Here, you have to go right up to the cap edge, but when you're doing the inferior dissection, stay within the center of the lenticule and leave some anchors of tissue there so that the lenticule does not fold over. So we'll go to the superior dissection first now. So as you see here, when you're dissecting superiorly, you go right up to the edge of the cap. And you have to move like a windshield wiper. Don't move from side to side. You have to move from like a windshield wiper, pivoting within the incision, so you ensure you don't tear the cap at all. Now, here comes the catch. When you're doing the inferior dissection, you'll be tempted to go all the way to the end. Do not do that. Go to the inferior dissection and only stay within the lenticule center. Don't move out of the edge of the lenticule. We must keep the edges of the lenticule intact in this setting. So as you see here, the edge of the lenticule is still intact, but the center is all fully dissected. Once you've done that, you can start to separate the edge, but keep anchors of tissue intact so the lenticle does not fold over. If you just do it in one sweeping maneuver, the lenticle will fold over and you will not be able to find it so easily. So what you do here is, in the final step, ensure that there are some anchors of tissue intact, and then you can very gently do the edge dissection in one half. So I'm doing it now from the 12 to 6, and then I'm leaving an uncut edge there on purpose. So just there to anchor the lenticule, and then do it in the other half. So once you've done that, as you can see, the edges are now separating, but the lenticule is not folded over. So because of this, you will have a nice fully separated lenticule which is not folded over and can be very easily extracted. So that's the final separation. And after this, as you can see, the lenticule will just come out very easily with no resistance at all. So that's the end of it. It's a fully intact lenticule and it can be very gently extracted out with forceps without any difficulty. So to conclude, you have to adopt a repeatable technique for lenticle dissection to perform every case. And also in doing it, pay attention to the proprioceptive feedback on your fingertips, so as you know where the resistance is during the lenticle dissection. And ocular surface preparation and energy optimization come first. Only if you get that right will lenticle separation be easy. Thank you for your attention.
So I'm back again to talk about phakic IOLs. So ICLs now, phakic IOLs basically, it's going to be a very short talk because of the time that has gone by. Um, in ICLs, basically, now these are some of the important points for beginners as well as for those who may face some of the problems that I have faced along the way initially when I was doing it, sometime around 2010. Of course, like any other refractive surgery, you have to get the basics absolutely correct. And always stick to the limits of the white to white and the anterior chamber depth as is prescribed for all phakic IOLs by the manufacturer. So, namely, not less than 2.8 and always above 11.5. Minimize air drafts when you're loading and always load the ICL and keep before you start on the patient. The ICL is a very delicate object, especially the central optic, which is very thin. So it would be a good idea only to use prescribed instruments and touch the haptics. So this is a short video of how to load the ICL correctly. You can see that instead of the ICL being pulled into the the cartridge is passed over the ICL and it's locked in place, and then the soft tip applicator is pushed forward, which makes sure that the ICL does not suffer any damage. And as you are inserting it into the eye, the tip has to go inside the incision and the ICL has to be injected very slowly, in such a manner that even if it's flipping to one side during the injection, you can always turn your cartridge and bring it to the right position. The haptics need to be tucked in gently into the sulcus, and that can be easily done with a Vukix manipulator. Now, sometimes you may have an untucked haptic in the anterior chamber, and that's easy to detect if the pupil is slightly small because of the manipulations that have happened, and you can tuck it back. But in case you have a haptic that is outside in a very large pupil, it may not be hard to detect, especially because it's a very thin transparent haptic. And so you have to be very careful that you have tucked all the haptics in before you come out. Otherwise, you will need to take up the patient again the next day and would have already damaged a few endothelial cells by then. Similarly, when you're washing out the viscoelastic, the flow of current may lead to iris coming out of either the side port or the main port. So it's very important that you dilate the pupil first, even though it might have constricted during the procedure. So using a pharmacological agent before wash will be a good idea, to both wash under the ICL as well as over the ICL. And while we do that, we have to make sure that the flow of the draft that comes out, the fluid that comes out, is along the top of the iris and it comes out, rather than under the iris and pushing it out of the side port. Then this is something I've faced in around 2 patients so far. That could be because of overinflation of the chamber, where the pupil becomes static. The intraocular pressure rises, but the patient doesn't present immediately, usually in about 3 or 4 days. It resolves very slowly after good IOP control. But the pupil comes back only in a couple of months. Now, in case there is a rotation of the ICL from away from the axis, so a re-rotation of the ICL, this might sometimes rarely be required in keratoconus patients where the cylinder may fluctuate, or if a patient has had a trauma like in this case. Then the rotation of the ICL involves plucking it out of the sulcus from that point and repositioning it back, rather than just dialing like you would do an intraocular lens. So you can see how the manipulator picks it up from the sulcus and repositions it to the next position, and the same thing for the opposite pole as well. If the volt is very high and it produces peripheral anterior synechiae and angle closure, then that's an indication for removal of the ICL. Or if it has come so close to the lens and has caused cataract, that's another indication. So where explantation of the ICL is also a smooth procedure. You just need to take the haptics out of the sulcus into the anterior chamber, and the ICL is so pliable that you can pull it out through that 3.2 incision you had made initially. Now, when you do cataract surgery in a patient, now this is a patient who is post-traumatic with an ICL, he developed an anterior capsular cataract. You may either remove the ICL out of the chamber, do the cataract surgery and put in an intraocular lens. But this patient wanted a multifocal, so we did the procedure under the ICL, which can be done provided you have provided very good cushioning between the cataract and the lens doing all the procedures. Please remember that the ICL has been brought into the anterior chamber. There's a lot of viscoelastic between the ICL and the cornea as well. Being a soft cataract can be easily taken out with the coaxial. And this was followed by a multifocal intraocular lens implanted into the bag, along with the placement of the ICL back into the sulcus. So you'll note that all the procedure is done through one edge of the ICL after turning it in the direction of the main incision. Viscoelastics need to be washed out very well so that there's no formation of interlenticular membranes. Now, this is another patient who unfortunately had a retinal detachment, again following trauma, following an ICL. He got stuck by his own belt, it seems, and so this was the retinal detachment procedure being done under the intraocular lens. So that is also possible. Following that, the intraocular pressures need to be monitored very well. Thank you very much. Call upon Dr. Aditya again, who will be talking about presbyopic correction using KLEX procedures.
Okay. Yeah. So I'll just quickly take you all through press beyond laser blended vision. So it's going to be more of a theoretical talk because press beyond is essentially a form of LASIK. Only difference is you treat both presbyopia and emmetropia as well. So just to be clear, so it's an excimer laser-based corneal refractive surgery for the treatment of myopia, hyperopia, along with presbyopia also. So what we do here is, in the patient's eye, the dominant eye, we will target for planar refraction, whereas in the non-dominant eye, we'll target for minus 1.5 for near vision. But the catch is this is not just monovision, it's a blended vision. So a lot of people get confused. They look at this and they just say it's monovision. But the idea here is Press Beyond will extend the depth of field in both eyes using spherical aberration. So the dominant eye will also get some amount of near vision, even though it's only supposed to be for distance. And the non-dominant eye will get a good amount of distance vision, even though it's only supposed to be targeted for near. That's why Press Beyond is different from normal monovision. So rather than saying it's monovision, you can say that yes, it uses the concept of monovision but improves on all of the disadvantages by extending the depth of field by controlling a therapeutic amount of spherical aberration. So rather than calling it as a monovision, it's called as a blended vision treatment. So what exactly is spherical aberration? So this is an aberration that we are used to living with in a daily basis. So our lenses by nature are spherically aberrated, and as we keep aging, the spherical aberration keeps increasing. And also when we accommodate, when we look at something for near, the lens gets more spherical, and by nature we have more spherical aberration, and that gives us better near vision. So this is an example of spherical aberration. As you can see, this is a spherical lens where the peripheral rays are focused in front of the central rays. So that distance between the peripheral rays and the central rays gives rise to a circle of least confusion, like you see in a conoid of Sturm. So that circle of least confusion, whatever is in focus in this circle, will be in the patient's depth of field in that view. So this is what Press Beyond does. It induces a mild amount of spherical aberration to increase depth of field for the patient. But there is a therapeutic amount. You can't just increase spherical aberration and just keep thinking it's going to give you more depth of field. Beyond a point, it will reduce image quality. So the ideal amount of spherical aberration we need is somewhere between zero point 0.3 to zero point 0.5. So that's what we target when we do Press Beyond. So let's just look at a working concept of Press Beyond. So let's say the dominant eye, we've done Press Beyond and the patient is now reading 6.5. But because the spherical aberration is induced for this patient, the near vision in the dominant eye itself will come to N8, which is excellent. So the dominant eye itself has N8 vision. The non-dominant eye, which is targeted for minus 1.5, has a near vision of N5. But even with this 1.5, the patient is able to read up to 6.9. So typically with the minus 1.5, the patient could only read about 6.18 or 6.12, right? But because of the presbyon profile and spherical aberration, even the near eye has good distance vision. So when the patient is blending together, their vision is amazing. They have 6.5 and 5 both for distance, intermediate and near. The refraction protocol is what is very, very important in presbyon. There's a very strict protocol to follow, where the patient has to see which the dominant eye is, which the non-dominant eye is. You have to keep pushing for maximum spherical acceptance in plus and maximum cylinder. So we want to get all the cylinder out of there. And we do the presbyon trial and we see whether they're accepting the plus 1.5 in the non-dominant eye. This is the most important part of presbyon. So what we did is we did a study where we took a series of eyes which are treated with presbyon and we saw the refractive outcomes and as well as the eye trace observed depth of field. So what we did is we looked at the eye trace, which is an aberrometer, and the eye trace tells us how much depth of field that the patient's eye actually has. So this is a very objective measurement of the patient's depth of field. So like you see here, this is an example of the eye trace. As you can see in the x-axis, you have the refraction, and you can see this patient is slightly myopic, and the y-axis we have the image quality. So the eye trace gives us a measurement of the image quality in terms of aberrometry. So in this refraction, the patient has 100% image quality. And beyond the 30%, beyond the 30% cutoff is where the image quality is no longer very useful for the patient. This is how we calculate depth of focus. So this patient has a depth of focus of 1.25. So when you do presbyon, the extended depth of field gives rise to a 1.25 diopters of extended depth of field. And the other eye, which is more myopic at minus 1.5, it blends with the other eye and gives us an effective range of focus almost up to 2 diopters. So the patient ends up having a very good range of focus. So if this is a patient who's just wearing single vision glass, the effective range of focus is about 1.25. When they were wearing a varifocal glass, like a progressive glass, the range of focus is about 3.5. This is what we try to emulate with presbyon. So what we found in this study is the pre-op period, the depth of field increased in compared to the post-op. So the effective range of focus in all of our patients put together was about anywhere from 2.5 right up to 4 diopters. So that means even a 50-year-old patient after getting Presbyon done has an effective range of focus between 2.5 to 4 diopters, which is amazing. So the outcomes are also very good. This is also a study I did with about 22 hyperopic patients, and I followed them for 6 months. 95% of these patients had 6.6 with N5, and 81% of these patients had 6.5 with N5. This is in hyperopia. Similar results in myopia as well. We found myopic patients 100% had at least 6.6 N6, whereas 60% of patients had 6.5 with N5. And also, as recently in February, I performed Presbyon for my own father as well. He's also an ophthalmologist. His age is 67. He had no cataract. We did the Presbyon on a Monday afternoon, and on Tuesday morning, we saw his vision. He was 6.5 with N5, and the next day morning, he's also operating cataracts. There is no issue at all with blending. There's no issue with depth perception. Very comfortably, just about 18 hours after surgery, he's back to the theater operating his own surgeries with no issues whatsoever. The most encouraging part is when you offer a presbyopic solution instead of a lens exchange solution, patients will be much happier to take it up. Our volumes of presbyopic patients we have treated in the last 1 year has enlarged exponentially. We used to do about maybe before introducing Presbyon, we used to do maybe 3 to 5 clear lens exchanges for presbyopia in our practice every year. But now, as of the last 2 months, we have done 10 Presbyons every month. So it started from 2 to 3 a month, 4 to 5, and then we're slowly coming up to double digits. So patients do want a solution for presbyopia, and they would like it to be a laser and not lens exchange. So this is what we've seen in our practice. So to conclude, it's an excellent option for the correction of presbyopia in the absence of cataract for both myopes and hyperopes. But it's a very intricate solution. You have to be onboarded with the exact standard operating procedure. I would highly recommend that you attend the Presbyon courses by London Vision Clinic before you start to adopt this procedure in your practice. Thank you for your attention.
Thank you very much, Dr. Aditya. So we'll keep the questions to the end of the session. I now invite Dr. Vanshri Nair. She is a consultant in refractive and cataract surgery at Giridhar Eye Hospital, and she shall be talking about lens-based refractive procedures, namely clear lens extraction.
Thank you, Dr. Swapna ma'am, for making me a part of this IC, and a very good morning to everyone here. So basically, refractive lens exchange, what is the role in spectacle independence is the talk that I'm giving today. So basically, we are removing the clear lens here to correct high refractive errors or presbyopia. So what is the role in today's practice? Just now we heard Dr. Adityan speak about Presbyon going way beyond the previous days and doing well now. So there are still some, criteria where you may find this a better option. So age and the refractive error is what actually matters when you're taking a decision. So very high refractive errors, like very high myopes or very high hypermetropes, which may not be amenable to LASIK or even ICL, IPCL for that purpose. And when you're looking for a permanent solution for presbyopia, this is becoming a very popular term called as prelex, which is being used by surgeons as an option to give to the patients as a treatment, a permanent treatment for presbyopia. So, as refractive surgeons, the first thing we think of is the cornea-based procedures. If that is not possible, we go to ICL. If that is not possible, then the last option left is refractive lens exchange. Why it is the last option? Because it's an invasive procedure, obviously. So compared to laser procedures, the risk of retinal detachments, endophthalmitis stars, vitreous loss, which is similar to cataract surgeries, that risk is there. So that is the con. The pros is basically relatively a permanent solution that the patient thinks that he'll not going to develop cataract later on. So at one step, your thing is done. I'm free. So that becomes a pro. Now, coming to really very high myopes, the things that we need to keep in mind or consider is that we need to get the retina thoroughly checked, because if the PVD has not already occurred, then there is a increased risk of retinal detachment in these patients, and in a clear lens young patient, a risk of RD, can be quite disheartening. So a prophylactic barrage laser may be required if there are these minor changes in the periphery. And the type of IOL will again depend on the lifestyle requirements of the patient. Hypermetropes, yes, they have an advantage with clear lens extraction because these are smaller eyes. So many a times you don't have the AC depth for the ICLs. And laser procedures, as we know that there are higher chances of induced higher order abrasions in the hypermetropic corrections. So this could be a good option. But if they are really small eyes, then again choroidal effusion is something that we need to keep in mind and keep a vitreoretinal surgeon backup as well, if need be. Presbyopes, not the late 40s and early 50s. These patients have clear lenses, but they have lost accommodation, and some amount of dysfunctional, lens syndrome is already set in, which cannot measure on the Snellen's chart. But if you see the contrast sensitivity, it has probably dropped. So these patients who are looking for a permanent solution to reading glasses, again, Prelex is an option. Going to the biometric consideration, it is similar to cataract surgery when we are offering a premium IOL to the patient. It is same over here that we have to keep an eye. But again, here we are dealing with really long and short eyes. So we need to be careful with the biometry that we are going to look into and the formulas that we are going to use. So also take multiple readings so that we are sure about what we are calculating. So we have the modern optical biometers are really doing a good job in compensating for the posterior corneal astigmatism. Some are calculating the true corneal astigmatism like the IOLmaster 700. And of course, we have good online formulas available now, which give us the confidence that we are putting in the right lens. So I'll just, So going to the toric considerations, since we are exchanging the lens over here, so we have to be sure that the astigmatism is corrected in a precise way. So there is a small consideration that the cornea, as it ages, will go from with the rule to against the rule astigmatism every 5 years. So it is the anterior with the rule astigmatism that shifts towards the against the rule astigmatism. So it is better to target a slight amount of with the rule astigmatism, around 0.35 is what they're saying when you're operating younger patients. Again, do your eye trace or corneal tomography to confirm how much is the corneal higher order abrasions for spherical abrasions. Check the chord mu, because here you're going to put a trifocal IOL. It better be centered well to prevent the glare and halos that might come up. Various options are there depending on the patient's liking. So you'll rather go for a trifocal or sometimes the newer EDOFs, which are doing really well for the patients. So I won't go into the details of these, but one point I would like to mention is when you're operating hyperopes, they have high angle kappa. So the problem of glare can come here. So ensure that your chord mu or the angle kappa is within 400 microns here. So this is a diagrammatic representation, like if you can see the pupil center at number 2 over there, and at number 1 where you have the visual axis. If the chord length between them is more than 0.5 or 0.4, then you may have the problem of glare and halos. So this is just a comparison between the two IOLs. Whether if there's a larger bull's eye in the center, then the problem of glare will be less, but that has a lesser add power. Coming to the intraop considerations, so we are operating on relatively younger patients. So remember that the sclera is going to be soft capsule, so the rhexis may be a little difficult. Better to use a forceps to have a well-centered rhexis. Soft nucleus, not much phacoenergy required. Eye may be just enough to take it out. Again, very high myopes, the lens iris diaphragm retropulsion can occur. That causes discomfort to the patient during topical anesthesia. So just before you start your irrigation, just lift up the edge of the iris so that the diaphragm doesn't go down and there's no reverse pupillary capture. So refractive lens exchange can be one option in your armamentarium if the patient is right and it has a healthy ocular surface. Just some contraindications to remember: if there are any corneal pathologies, uveitis, uncontrolled diabetes, uncontrolled glaucoma, previous keratorefractive surgeries, then these patients are not for lens exchange with a trifocal or an EDOF lens. So to summarize, again, realistic expectations, check all the calculations twice or thrice. Do your biometry on a fresh days when there is no surface manipulation. Thank you.
Thank you very much, Dr. Manushree. I think we can take a few questions. Manushree is someone I wanted to ask about. What is your how young will you go for a refractive lens exchange?
I would say after 48, because before that, if it's a high myopic patient, then after 48. If it's a high myopic patient, the chance of retinal detachment would be higher because there's no PVD induced. If it is a hypermetrope, then at any age would be okay. Should not be a problem. But depending again on the refractive error that you're correcting. If it is a smaller refractive error and it is amenable to other treatments, then yes. I'm impressed with Press Beyond.
And with your experience with Presbyon, how do you compare it with the other presbyopic LASIK treatments that are currently available in the market?
Okay.
Would you be able to comment on?
Okay, so the main difference is Press Beyond is not multifocality. See the other presbyopic LASIKs like Supracore or Presbymax, it creates a central zone of steepening for near vision and a peripheral zone for distance. So essentially, you're trying to simulate what you have with a trifocal IOL. With Presbyon, there's no separate zones. It's a smooth zone like an EDOF. It's got no bumps, no extra curvatures, nothing. So what you get is you don't get loss of lines. If you see the published results on Presbymax and on other multifocal corneas, there's loss of best corrected visual acuity. So the distance results are not so great, whereas you don't have that with Presbyon. So there's no loss of contrast, or at least there's minimal loss of contrast. Results are much better, and there's no loss of best corrected vision. That's the main difference.
Thank you very much, Dr. Aditya. So if there is to Dr. Chandrakant. Please use the mic.
Regarding the peripheral retinal degeneration, high myopes and all, the lattice is there, maybe 1 or 2 lattices. Holes are there, you are going to do a barrage. Okay. How much time, what is the time duration from the barrage and your surgical procedure?
So at least
minimal,
2 weeks.
Minimal.
2 weeks is what we prefer. 2 weeks.
2 weeks. I don't agree 2 weeks. I think what I think is at least minimum 1 month we should be there for the inflammation, everything to settle down. Especially you're doing a procedure on a clear lens and all. I think at least, and again here also, if there are no vitreous stacks on the periphery and all, then it's okay. Yeah. But if you have got a barrage and a retinal hole, done a barrage, minimum 1 month, I think it's ideal
So
thing.
I think that again depends on the nature of the lattice, like you mentioned, with the vitreous tags and how much of, holes or the extent of because we have our retina surgeons advising us for 1 month in some cases, but in most of the cases where it's just, more of a cosmetic procedure, just to make sure that there is under no circumstance any chance of retinal detachment where you barrage even the smallest of lattices, then maybe 2 weeks might be a good option.
What about how many lattices? Say there are.
So actually, we honestly to say, we don't decide that time. We ask our retina colleagues to give us an opinion because they are the one doing the barrage. So I prefer that. But what I've seen in my institute is usually around 2 weeks for some.
But after the surgery, you got some problems. They'll come not to be held responsible. The patient held responsible. You catch you. Okay. Let's be careful on that.
Yes, sir. Definitely.
Okay. Thanks.
Thanks. Yeah, I wanted to ask a question about Press Beyond. Actually, you have done Press Beyond for patients who are, say, in their 50s and 10 years down the line, they are coming for cataract surgery. So does this Press Beyond act because of the spherical aberration, it's going to take care of the depth perception? Yeah. So do you go for a purely monofocal lens after that, like for cataract?
Yeah, so to be frank, I've still not done a post-presbyopic cataract surgery, but like you said exactly, because they already have enough spherical aberration in the cornea, we just have to put in a monofocal. Okay. So maybe aim for a plano aspheric monofocal, which got no spherical aberration.
Zero, not the negative one.
Zero,
yeah,
zero. You've got zero. So you put plano on the dominant eye and target minus 1.5 the non-dominant, just like how it was before Presbyon. Okay. So because they've already adapted to that, you just have to simulate the same thing again.
Okay. Okay.
Yeah.
So it's better that they have all the data that is done at the time of presbyopia when they come for the cataract.
Correct. No, not exactly. If you have an eye trace and aberrometer, you can measure it anyway. Even if you don't have the exact data with you, you can still measure the amount of spherical aberration and implant aspheric. That's it.
Okay. Yeah. Thank you.
So, Priyanka, did you want to ask something? No. Okay, so with this, we come to the end of our session. And yeah, we have people waiting here for the other session. Thank you very much to all my speakers. Thanks for making it today.